So current treatment guidelines for acromegaly recommend surgery as the primary treatment in most patients. However, we know that medical therapy also has a role either in first-line treatment as an alternative to surgery. So for those patients with high surgical risk, those who refuse surgery, but also those who've got invasive and unresectable tumours, or as an adjuvant therapy. We know that second generation long-acting somatostatin analogues are the first-line medical therapy in acromegaly patients. And studies suggest that 3 to 6 months of pre-surgical treatment with lanreotide or octreotide might improve the surgical cure rate in newly diagnosed patients with acromegaly at 3 and 6 months of follow-up. We also know that previous studies suggest that somatostatin analogues, when used as first-line therapy, can also have significant tumour volume reduction. And in fact, this has been shown as early as at the end of the third month of treatment with lanreotide 120 milligrams, when used without any dose titration. But what we don't know at the moment is that there's no published data regarding what happens before 3 months. So moving on, we know from data from a multi-center study back in 2015 that optic chiasm compression is observed in about 18% of patients with growth hormone secreting pituitary macroadenomas. And in those cases, transsphenoidal surgery is usually proposed as first-line therapy because that allows the removal of the tumor, but also it relieves the optic chiasm compression. And one of the issues is that currently it's unclear what effect somatostatin analogues have in this context, as there's no published data. So based on the background literature, the authors considered that the unanswered questions in this area were, firstly, what is the early efficacy of somatostatin analogues in reducing tumour volume and or improving the ophthalmic symptoms, especially at that first month of treatment? And secondly, what is the short-term anti-tumoral efficacy of somatostatin analogues in patients with acromegaly and optic chiasm compression? So with that in mind, what they did was they conducted a retrospective study to assess the efficacy of treatment with lanreotide 120 milligrams administered every 4 weeks in somatostatin analog naive patients, so without dose titration, and then looking at the effects on tumour shrinkage and ophthalmic symptoms after 1 and 3 months of treatment.
These patients who had not had surgery?
Yes, so these are newly diagnosed patients with no previous treatment. So regarding the methods, so this was a single centre retrospective study that they conducted at the Department of Endocrinology at Lille University Hospital. So as you were alluding to, Profs, these were newly diagnosed patients with acromegaly. They had cavernous sinus invasion and or optic chiasm compression. So they had grade 2 and below. And I'll just bring up a slide in a couple of slides' time just on the grading system. So these were pituitary macroadenomas on MRI scan, and these were patients who had no previous treatment and were naive to somatostatin analogues. So patients were excluded if they had any of the following. So a history of prior surgery or radiotherapy or medical treatment for their pituitary macroadenoma, a history of pituitary apoplexy, if they had co-secretion of prolactin, so their cutoff was 100 micrograms per litre, which I worked out is about 2,000 milli-international units per litre in our units, as well as patients who were being followed up by CT and not MRI because they had contraindication to MRI scanning, as well as any patient that required immediate surgery because of neurological symptoms or they had an emergency condition. So things like severe visual deficit, severe optic chiasm compression, so grades 3 and above, or clinical or radiological evidence of pituitary apoplexy. So just as a reminder of the grading system for optic chiasm compression, because this will be relevant for some of the later slides, the severity is graded from 0 to 4. So 0 means that you've got a tumour that doesn't have contact with the optic chiasm. Grade 1 indicates you've got contact between the tumour and the optic chiasm, but that the upper surface of the optic chiasm isn't affected, so there's no deformity. Whereas with grade 2, you have contact with the upper surface deformity of the optic chiasm, but you've got a visible suprachiasmatic cistern. Whereas with grade 3, you've got contact with the upper surface deformity, but you've got an invisible suprachiasmatic cistern. And then grade 4, which is the highest, indicates you've got contact and you've got cerebral deformity. So back to the protocol, those patients who had eligibility were discussed, and a best treatment option between 120 milligrams of lanreotide every 28 days before surgery was chosen.
I don't think it's today. So which is even worse. Why are you bringing them in here first?
Gastro doctors, could you just mute Hemant's computer, please?
Thank you. And of those who received lanreotide, a baseline clinical examination, hormonal profile with growth hormone and IGF-1, as well as an ophthalmic evaluation and a pituitary MRI was taken before their first dose of lanreotide. And then they had exactly the same evaluation performed at 1 month before the second injection, and then at 3 months just before the fourth injection.
Was it randomized, Ed?
No, so it's retrospective. So they went back through their cohort between 2015 and 2021.
Okay, sorry, I missed that.
No, it's okay. So this schematic shows the flow of the participants into their study. So from 2015 to 2021 at their centre, 59 patients with newly diagnosed acromegaly were followed up in their department. Of those patients, 38 were excluded either because they were macroadenomas without cavernous sinus invasion or optic chiasm compression, or they were microadenomas, or they needed emergency surgery, or they had apoplexy at diagnosis. So then this left 21 patients because one of the patients was excluded because they didn't have a full evaluation at 1 month of treatment. So this therefore left 21 patients who were included, and they had full clinical, hormonal and MRI evaluation at baseline, and then again after 1 month of treatment with lanreotide. And then at 3 months of treatment with lanreotide, only 17 had the same evaluation because 4 of the patients were operated on before their 3rd month. So that was because either they had a lack of significant tumour shrinkage with persistent optic chiasm compression in 1 patient, or as well as mild worsening of their visual field defects in 3 of the patients. So that left 17 at their 3-month evaluation period. So this table summarizes the patient characteristics and the hormonal profiles at baseline, and then again at 1 and 3 months of lanreotide treatment. And you can see that the median age acromegaly diagnosis was 48 years, and that the gender distribution was fairly balanced. So there was 11 women and there was 10 men. We can also see that treatment with lanreotide produced quite a significant decrease in the mean serum levels of growth hormone after the 1st month of treatment. However, there wasn't a significant change then observed between 1 and 3 months of treatment, probably suggesting the fact that the vast majority of the hormonal response seems to be in that 1st month. Then in terms of their IGF-1 response, they had very similar results, although slightly confusingly, they express their IGF-1 levels as IGF-1 percentages, which means that they've worked out as a percentage of the upper limit of the normal range. The reason being in that half the participants, they used 1 assay, and then in the other half of the participants, there was another assay that they were using at the time. So they tried to work it out as a percentage to try and eliminate the variation caused by those different assay kits, mainly because each one had a different age and sex adjusted normal range. But if you take that into consideration, despite the short follow-up period that they had, 5 out of 21 patients had normalized their IGF-1 levels after 1 month of treatment, and then 5 out of 17 after 3 months. So This table provides the data regarding the tumour and then the ophthalmic features. And I'm not going to dwell too much at the 1-3 month stats, because I think the data is probably better visualised in their figures. But we can see that the median tumour volume at baseline was about 4,500 millimetres cubed, and that the mean largest diameter of the tumours was just under 3 centimetres at baseline. Then in terms of optic chiasm compression, that was observed in 14 of the patients, so about 66%, sorry, yeah, 14. And that there was cavernous sinus invasion in 10 cases, so about 50% of their participants. That was in 1 participant based on class 3, and then 9 participants in class 4, according to the Hardy-Knox grading system. So just as a reminder, this is a system that grades the paracellar extension of the tumour towards the cavernous sinus in relation to the ICA, the intracavernous carotid artery. So grade 3 and grade 4 suggests cavernous sinus invasion. And really the defining feature is that the tumour extends beyond the lateral margins of the supra and intracavernous ICA. Whereas in grade 2, the tumour extends beyond the intercarotid line, but it doesn't extend beyond the lateral margins.
And this is very important for acromegaly, because if you're a grade 3 or, well, if you're a grade 4, you definitely will not be cured by surgery because they cannot get around that carotid. Grade 3 possibly, but what you want is to convert a grade 4 to a grade 2 with lanreotide. That's a hypothesis I'm just putting out there.
Yeah, okay. So turning to their tumour shrinkage results. So figure A shows the tumour volume reductions for each individual participant from baseline to the first month of treatment. So there's 4 black arrows and they indicate the participants who were operated on before the 3rd month of treatment. So what they did is they deemed significant tumour shrinkage as being anything over 25%. And what they identified was that 13 out of 21% at the end of the first month, so 61.9%, had significant volume reduction. Then in figure B, they do a very similar way of depicting their data, but what they show is that the tumour volume reduction for the individual patients from baseline all the way to the 3rd month of treatment. So you've got to bear in mind that obviously they've lost 4 participants. So what they did was a intention to treat analysis, and they calculated a significant tumour shrinkage, so 25% or more, in 14 of their 21 patients. So that was 66.6% had significant reduction at 3 months. Figure C then combines A and B, and it shows the percentage changes in tumour volume from baseline to follow up at 3 months for the 21 participants. And so the blue dashed line is meant to represent the 25% reduction of tumour volume, which they deemed as significant. So I'm going to come back to figure D in just a second, but I'll just remind you all of this table from the start, which shows the median volume at baseline for all 21 patients, which was 4,543 millimetre cubes. That's all 21 patients. What they've done rather confusingly in figure D is they've removed the 4 patients who were operated on before 3 months. And whereas before they were always quoting the median value, they're now quoting the mean value. And so this is now made up of 17 patients who had the full 3 months worth of data. And you can see that the mean tumour volume is now 10,000 at baseline, whereas before, when they were quoting all 21, it was 4,500. So obviously the 4 that were excluded clearly had smaller tumours, whereas now we're at 10,000. So what they've done is they've done an analysis and showed that in those 17 patients with volume reduction, it was more pronounced at that first month of treatment, which seems to be very much in keeping with the hormonal responses that they observed at the start. And so in that first month, the percentage volume reduction was minus 37.2%. And it was more than the reduction that they saw between the first and the 3rd month, which was minus 20.6%. Again, obviously suggesting that much of that response that they see is at that first month of treatment. And then when you look at the all 3 months together, the mean percentage of volume reduction from baseline up until the 3rd month was minus 50%. Okay, so they do pretty much the same analysis for the largest tumor diameter. So I'm going to quickly just run through E to G. So figure E shows the largest tumor diameter reduction from baseline to the 1st month of treatment. Again, those 4 black arrows are the 4 participants who were operated on before the 3rd month of treatment. Then F is the largest tumor diameter reduction from baseline to the 3rd month of treatment. And then G again is the percentage change in the from baseline to follow up in all 21 participants.
So Ed, can you just go back to the previous slide, the one that went from 4,000 to suddenly 10,000?
Yeah.
So can you explain what kind of volume would that be? Because that's a huge change for 4 patients.
But also those were the 4 patients that were operated on because they caused compressive.
Yes, it doesn't. That just doesn't make sense, does it?
No, it doesn't. And actually what they don't really give you is what they don't break down those 4 participants to tell you what their characteristics were, because you've got to assume that their tumors, if it's gone from 4,000 as the median to now 10,000 as the mean, they had to have been tiny tumors for that change.
Oh, I see. It's gone
These
from
are
mean to
micros.
median. So they might have been not that small, but they actually just need to be a little bit smaller. And the median, moving from mean to median is a real cheat, isn't it?
Yeah.
Done that on purpose.
I guess
to
so.
make the number bigger.
Yes. That's very unfortunate that they don't give us the actual, or even the range would be helpful. Okay, I understand now. Thank you.
So then in terms of H, so similar to the tumor volume reductions, they observed that the reduction in the largest tumor diameter was more pronounced at the 1st month. So the mean percentage reduction was essentially minus 15%, whereas between months 1 and 3, the mean the mean diameter reduction was minus 8%. And then across baseline through to 3 months, the mean percentage reduction was minus 21% in total. And then all 3 of those were significant. But obviously, again, this is made up of 17 rather than the full 21, which they start with. So then in terms of the ophthalmologic symptoms, so at baseline of the 14 of the 21 patients who had optic chiasm compression, 10 only had visual field defects, whereas 4 had visual field defects and moderately decreased visual acuity. So then in terms of the responses, after 1 month of treatment with lanreotide, you had visual field normalization or improvement that was observed in 7 out of the 14 patients, so 50%. And then there was stabilization in 4 out of 14, meaning 30%. And then in 3 of the patients, they had mild worsening that was observed without any alterations in their visual acuity. And they were 3 of those 4 patients that then went on to have surgery before the 3rd month. Then in terms of those 4 patients that had decreased visual acuity at baseline, visual acuity improved in 2 of those, and then there was stabilization in the other 2. So in terms of their safety data, they say that there were no serious adverse events that were related to the use of lanreotide that they recorded in their study. The most frequent side effects, most commonly in the first couple of days of treatment with lanreotide, was diarrhea in about 50%, abdominal pain in another 50%, and then headaches in about 33%. So to summarize their findings, they show that in patients with newly diagnosed growth hormone secreting macroadenomas that had cavernous sinus invasion and or optic chiasm compression, so grade 2 or less, they showed that primary treatment with lanreotide at 120 milligrams every 28 days appears to provide a significant and sustained tumor shrinkage. So from their data, they show that there was significant reduction, so over 25% in tumor volume in 2/3 of their patients at the 1st month of evaluation. They also show that it also appears to improve optic chiasm compression and visual symptoms by the end of the 1st month of treatment. So after the first month of treatment, of those patients who at baseline had optic chiasm, compression, and visual field defects, the visual fields appeared to normalize or improve in 50%, and there was a stabilization in 28.5% of their cohort. So the strength of this study appears to be the fact that it's got quite a homogeneous protocol in terms of the treatments and the diseases. They've obviously used one single dose of lanreotide at the highest dose, so there's no dose titration. So obviously the dose data is probably homogeneous. The MRI analysis was all done by the same blinded radiologist. However, obviously the data comes from a single center, it's retrospective. They've also got quite a small number of patients, which probably limits the generalizability of their results as well. So in terms of how this paper could influence clinical practice, it gives us data on the fact that patients with non-severe optic chiasm compression, so grade 2 or less, and an invasive tumor that wouldn't be curable by surgery, in those patients, lanreotide as 120 milligrams could provide a first-line therapy that may avoid surgery, whose other objective would only be to preserve visual pathways. Also suggests that in those patients who've got multiple risk factors that where surgery would be dangerous, that lanreotide medical therapy could be beneficial for them as well. So as a final slide, this is what they do at their center at Lille University Hospital. So they offer a primary medical treatment for all patients who've got cavernous sinus invasion, even if there's mild optic chiasm compression, so grade 2 or less, and non-severe ophthalmic symptoms. So patients are then only referred for surgery if their ophthalmic symptoms worsen, or in the case of non-tumoral volume decreases and persistent optic chiasm compression. So essentially, they do the protocol of what they did in this study. So they do a complete evaluation at 1 and 3 months after starting treatment. And then if there's any deterioration or there's no significant improvement, then they are the patients that they then refer for surgery. I think that was all the stuff I've got.
I think we sort of do that without thinking too hard. We do give people lanreotide at the start. Sometimes I'm hoping it'll turn a macro. It would move from, you know that picture you showed of the tumor around the carotid, move from 4 to 3. I've never seen that happen.
Yeah.
Did they didn't say anything about that, did they? About going from 4 to 3?
No.
So Ed, when the data came out showing that there is shrinkage, obviously with somatostatin analogues, the guidelines still refused to put that in as a step before surgery.
Right. Okay.
Not understood.
But it's money, probably money.
Is it just? But this is endo citing. Nice. Why would they not? What's the counter argument?
Well, now there isn't really. We've got plenty of evidence. So when we do it, we give it first.
Yes, but it wasn't in the guidelines with all the data. It says surgery
At the start, but
first.
yeah. So well, surgery still okay.
And do we give it as a fixed 120 milligram dose, or do we dose titrate?
We give 120 milligrams.
Yeah.
It depends on who sees the patient. Sometimes it's less.
There's no point.
Florian.
Yeah, see, but the question really is, does it improve surgical outcomes? I know this wasn't the purpose of this paper because it was sort of medical treatment versus surgery, but we actually give it often when surgery is delayed, or we hope that it would actually make surgery easier. But that hasn't been shown. So no one has shown that actually it doesn't improve the surgical outcomes.
And also, they didn't operate on the other 17 at all.
No, they did not. No.
So we don't know what happened after month 4 because
no.
You see, so that's the problem. The problem. I mean, I'm keen, as Florian is I agree with Florian. We should give them 3 months of treatment, and then operate.
So the key, I guess the answer to my first question is because we don't know whether it actually makes a difference. So it makes it look
Correct.
Like, but we don't know whether it actually changes the outcome.
Yeah, and to prove it changed the outcome, you need a randomized controlled trial of people who get surgery, and that's not going to happen because we're going to choose people for. Well, we could, I suppose. The problem is we're at the mercy of waiting lists and things. So what happens in reality, this is a long waiting list, then on that particular occasion, they get a bit more lanreotide. I think we should, what do you think, Florence? Should we not give it to them all when we see them as they're getting ready for surgery, even a month? Only have to say that because Ed has just showed us that at 1 month there's a 25%.
But will it be?
I don't know.
We don't know whether it makes a difference to me. That's the thing. So if someone gets surgery pretty soon, it probably doesn't. But yes, I mean, in reality, no one is being operated on within a week or two. So I think we probably should.
Yeah. And in a month, am I right, Ed? There's significant shrinkage in 2/3.
Yes.
At 1 month.
Yeah, let me just go to.
Selected data.
Yeah.
We do that anyway. Sorry, I missed the time.
Yes, we do. That's what I'm saying. We do it anyway. So no, but we don't always. We kind of go, oh, do you think they can operate in a month? All right, then we'll not give them lanreotide. We shouldn't do that. We should give them all lanreotide.
We probably should, and even though it may not make such a difference to tumor shrinkage and surgical outcomes, it will improve the metabolic profile and cardiovascular risk for surgery. That's another point to consider, isn't it?
I think you're right. I think you're right.
So the main message is give it before, wait at least a month, but we don't need to wait 3 months, are you saying? Or if longer is better?
No, I'd like to operate as soon as possible, but I'd like, if they're gonna, the minimum wait is a month, isn't it?
Yeah, in the past we were worried about growth hormone assessment after surgery, but actually it's probably not such an issue, isn't it? Because we don't reoperate, we don't tend to reoperate straight away afterwards anymore.
No.
So we just have to wait a bit longer.
And I guess in these patients, all of the hormonal response and the effects on the tumor, they saw it within the first month anyway. That difference between 1 and 3 months wasn't significant because most of the effect had already happened in terms of the response, the benefit.
I think it's a good paper. I think they've done well. The other thing is you say it's a very small list, but actually these are only the ones that were right up against the chiasm. They must have done lots of other slightly smaller ones. Yeah, so I think it was, of their new acromegaly patients, it was 59, but then 37 were excluded, and they're the ones that are shown on the left there. Yeah.
Anyone for surgery?
Yeah. I think
so
it's,
the more, I mean, you might expect more of those ones that ended up going straight surgery to respond well as well if they were bigger, hypothetically. I mean,
yes, in fact, I'm slightly surprised.
Skewed, really,
it negatively. Yes. They might have waited a bit before rushing into surgery for those 4 on the basis of this.
And in the past, there was another thing that we were worried that it may actually make surgery more difficult because the tumor structure may change, but that doesn't seem to be the case, does it?